Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
Welcome to the show, Dr. Mark Vaughn and Dr. Gwen Vaughn, right here in person. Well, not in person. You're right, I do need to mute it. I forgot about that. Yeah. So we are going to be, we're waiting for our audience, our live audience, to chat in with their comments and questions so that we will have the topic for this week's show. Because it's been working out, I feel like it's been working out really well to have the audience
answer your questions,
determine what they want to be talking about. If they're going to be, and Rusty, look at this, we already have people here on the chat. Rusty's saying
look
hi.
At that.
I don't remember where
and technology is working for those
who are with us. And the technology is
us.
working. We're very happy about the technology work.
Yeah.
Last week, not so much, but this week, everything seems to be going. We got Rusty on board.
All right.
And I know that Lindsay Antwine is not too busy because she was sending me messages on Instagram Messenger about My Chemical Romance.
My Chemical Romance.
Yeah, she likes them a lot. No, I'm sorry. No, it wasn't My Chemical. It was Matchbox 20. I'm sorry.
Matchbox 20. Nice.
Yeah.
Now we're getting back to my age of music.
Oh, is My Chemical Romance then too?
Yeah, that would be when I was a little older.
I can't name one song. Okay. Oh, and Hilda Bauer also waving at us on the comment line. So we got
My
Rusty.
Chemical Romance does a version of Into the Unknown, which is a song that's on Frozen 2 that is amazing. There you go. There's my tidbit for the day.
They do the version that's on...
No, they do their own version of it.
Well,
it's
which one's
usually
better?
done by Elsa, who is played by Idina Menzel. And obviously, she's a wonderful singer. But I actually prefer the My Chemical Romance version of it. There you go.
Who did it first?
Well, probably Frozen 2. The Idina Menzel version, I would imagine.
Oh, okay.
It's actually in the movie, though. I think they play it over the credits.
Oh, it's credits. That's where it happens. Okay.
You're not up on your Frozen 2.
Rusty B is saying, the insurance company CEO shot in my
Oh, my gosh.
by a hater. That certainly is interesting you should say that. I was, while I got here a little bit early, so I was going through my Instagram feed, and I found these anti-United Healthcare message or videos or posts because people had been denied something by them. I've not seen United Healthcare as the worst of them myself.
I know that they've stopped some of their services in the area. They're shutting down some of their United Healthcare plans.
One of their
Medicare Advantage plans.
Medicare Advantage plans, but there's others. It's not their only one.
Oh yeah.
Or we.
I don't think we run into many
or
issues.
Maybe it's. I'm sorry, I don't remember now. If we have other
maybe we're
carriers
just better at getting things covered.
That
maybe or not ordering things that are unnecessary.
Yeah. Well, the example was in the Instagram feed was an anti-medic for a child on chemotherapy.
Oh, geez.
Which sounds unbelievable.
Yeah, that you would deny that. Wow.
But also, I'm thinking that what they were writing for, it doesn't say. I think they're writing from Dancitron. And probably, you're right, and they probably cover something that's much less expensive.
Possibly, but
like
Zofran is generic these days. I don't know.
Is it?
I couldn't tell you. Yeah.
Maybe it was the one that melts in the mouth, the fancy one.
Maybe for a child that maybe not swallowing or something, or who knows.
Oh, I hadn't thought of that. Yeah, So, it's interesting. People make the insurance to be the bad guy a lot. I notice that even with us, with somebody comes in with atraumatic shoulder pain.
Yeah.
And when we say, well, no, we don't start the very first visit with an MRI for shoulder pain that didn't have trauma. That you can still use it for the most part. We don't jump straight to the MRI. That doesn't fix the shoulder.
Right.
And they'll give us the opportunity. They'll give the doctor the opportunity to make the insurance company the bad guy. Oh, they won't pay for care or whatever. Well, no.
That's why I say they won't, because
it's a waste of money to get.
That's not gonna
to get one at the first visit for every atraumatic shoulder pain that walks in the door.
Mm-hmm.
Yeah. So it's a misunderstanding of patients that somehow
backing up insurance companies, but. Usually we're on the other side of this conversation.
That's weird. That's suspicious. I'd start looking and seeing if we're being paid off by the insurance company. Because
look it up. Sunshine Act. See who's paying us off.
That's right. Oh, that's right. They can look it up. Maybe they can see that. Who was it? The hospice that gave us Dutch Brothers once.
They did do that. Was it Vitus?
Vitas. Yeah.
I don't know how they pronounce their name.
They were a guest on the show once. Okay, Lindsay Antwine has arrived. Woohoo! Oh! Now I know who we're getting paid off by. It's that $40 super chat.
Oh my goodness!
Everything they do is amazing. LOL. Here's some Dutch Bros money.
I don't know who she's referring to for they. Everything they do, because we were just talking about insurance.
Maybe she's referring to us.
Are you referring to us?
Thank you, Lindsay Antwine.
Or
wow.
Yeah. Or was that a ironic statement about insurance? I don't know.
Maybe.
Thanks for joining us.
Yes, thank you. We are so glad to have Lindsay Antwine on board, and she's glad that you like the My Chemical Romance song.
Yeah. Well, of course.
Yeah. So yes, that certainly is a health-related topic that's absolutely in the news. The United Healthcare executive who was brazenly
like broad daylight.
Would you call that an assassination, or do you have to be a political figure for it to be an assassination?
Murdered, gunned down.
Yeah.
I don't know.
But they caught the guy. Supposedly, we'll say they caught a suspect or a person of interest who just happened to have a weapon similar to the one that was used.
Suspicious.
And a suppressor.
Oh, wow.
On his person when he was seen at a restaurant. Is that what it was?
Which I would imagine is illegal.
Restaurant
in New
or store,
York.
gas station. Yeah. So he has the gun and he has a suppressor. Maybe it's just coincidence that he had those on him.
In New York?
No, he's in another state.
I thought he left the state.
Yeah. So, the thing that has been in the news is, wow, the murderer is getting some support, shall I say?
Praise?
But not, well, maybe by some parties, yeah.
Yeah.
But
right, that's kind of a weird thing that, or
because
all the things on my Facebook were, oh wow, what a good-looking person. Like I don't know if you had all that.
Wow.
Like all these. I don't do Twitter or X, but apparently there were thirst tweets about the.
So it's so strange. I remember being upset at the insurance companies for prior authorization stuff.
I still get upset at them.
But it seems my personal experience is less now.
Yeah, it's not that often that I need to do
makes the difference?
What's called a peer-to-peer.
Is it because we've actually had progress through negotiations between Sutter Independent Physicians or Sutter and the insurance companies to get us out of prior authorization? Because I believe they've done that in their negotiations, is they get rid of prior authorization for the doctors.
Which, yeah, or we're just very good at prescribing medications that don't require prior auths or ordering tests. I do fill out prior auths every once in a while for medications. It actually comes in on our little inbox.
Certainly we do. Well, I forward all mine to Tasha.
So she's doing all your prior auths.
So we do get them for the weight loss drugs.
Yeah. So
we've talked about before.
We've talked about those, the GLP-1 agonists.
Hopefully once
require
people get their weight off,
prior auth.
They will have a lifestyle change and be able to maintain. But
that's the hope.
Statistically, that's not what we see occur. Yeah. People depend on it to decrease appetite, which is a wonderful thing, but we really need it to cost less. Yeah. All right. I'm just going to put up. I love this. I love the super chat. So
everything.
I'd be fine if that's just the rest of the show. That
everything they do. Everything.
That's pretty cool. Yeah, that's all I have for the news, though. Is that they caught the person of interest or the suspect who just happened to have the suppressor on him, and United Healthcare is generally disliked because it's a health insurance company, and they're seen as the bad guy.
They are an easy scapegoat.
Yeah, but honestly, in my experience, it's not them. It's more the Blues or some of the others that aren't as popular. And maybe that's just based on our negotiating
which could be completely different in our state versus other states because we have different insurance. Well, maybe that's
Moved from Texas to California. All my meds are being denied for PAs. I wonder if it's because of the move. Did you change insurance when you moved? Maybe it's more a matter of changing insurance than the state you're in. I'm not sure. And actually, California, we have currently the CMA is, I believe, I hate to say this wrong, but we have an awful lot of talk of prior auth.
Right.
And I think
they're always trying to ease the burden because
it was last doctors. Year that maybe it passed. It was last year that it went before the legislature, and we were talking to. It's interesting. So even though it's California, the legislators that I was talking to, because of the districts I live in for the state Senate and for the state assembly, were actually Republican legislators. Mm-hmm. And they were both totally on board with controlling the prior authorizations. And I would guess that all of the Democratic ones, so I would think it would have passed if that's the case.
So.
I wish I really should know the answer to that. So it shouldn't be as much of an issue in California as other states because of legislation against prior authorizations.
Maybe that's why our burden is lighter.
Rusty B, have you helped any chronically ill patients try to get off
Advantage and on a supplemental plan?
No. We have excellent Medicare Advantage plans.
Where we are at, our Medicare Advantage plans are pretty good. The ones that we are members part or accept, the ones that we are.
You're contracted in a group.
It's like an HMO. That's kind of how a Medicare Advantage plan works. So the one that we are a part of is very, very good, and we're very happy with it.
Big fan of Medicare Advantage in our network.
And typically you have broader coverage as well.
You're getting benefits you don't get otherwise. Yeah. Where does the money come from? I'm glad you asked.
I'm pretty sure that's what Rusty was asking.
So the way it works is that they emphasize preventive care and reorganize the incentives, how you get paid in such a way that the patients don't have to use services or go to the emergency department. So the doctors are incentivized to take care of their patients so
keep
they don't
them healthy.
So they don't have to go to the emergency department. So having extended hours or weekend hours is one of the ways. Yep. Doing whatever you have to with your schedule to get your patient in so you can take care of them so they don't have to go to access. There it is. Yep. So they don't have to go to the emergency department. And keeping their chronic diseases controlled.
Yeah. So there are certain metrics that we need to meet as providers for our Medicare Advantage patients, or at least a certain percentage of them. Some of them are very difficult to get under control, but like blood pressure is one of those, making sure if a patient has high blood pressure, they're under a certain number, make sure their diabetes is under control, make sure they're getting all of their appropriate screening for their age, cancer screening like mammograms, colonoscopies, etc. So, and that's pretty kind of the way that medicine is going. It's called value over volume. The fact that
and it's sometimes done badly,
and it can be done badly. Absolutely,
there's some bad examples.
I've heard a lot of bad Medicare Advantage examples. So where you're at may be completely different.
There are some bad
than
ones
the
out
plan that we are a part of in California. But we're very happy with the one that we participate in. Yeah, and our patients are too.
It really is. One of the top ways of doing it that we've seen nationally, and we see that by looking at how much is it costing for care, how much patient satisfaction. You're on that end of it.
That is part of it too.
Because these medical directors, service excellence of Sutter Independent Physicians, a 500 doctor group here in the Sacramento area, and so they regularly are surveying the patients as they walk out the doctor's office to see, are you satisfied with your care? But that's just part of it. Patient satisfaction. The other part is, are they doing good care? Well, how do you measure that? Controlling blood pressure, controlling diabetes, blood sugar, getting screenings. Those are things that you can actually measure, and we're getting better at it.
They talk about, and this is actually an AMA thing, the quadruple aim of medicine moving forward. And that's 4 prongs of this, and the 4 prongs are quality, which is meeting those metrics to keep the patients healthy and out of the hospital that way, the blood pressure, et cetera. Patient experience, making sure that you provide a good experience for them. That's customer service. Utilization, which is making sure that patients are trying to avoid the ER and hospital if they don't need to,
and not getting an MRI on every
and that's part of utilization as well. And then lastly, actually the 4th one has to do with doctors to try to prevent burnout, but making sure your doctors are
wellness is the word they use.
I guess is the word. Yeah.
Okay.
So, yeah.
Let's see what we have. Rusty B.
I think that's what we just talked about.
Yeah.
So for those who may not, if you have Medicare, you kind of know the difference, but very high view, maybe we should first tell the difference between Medicare Advantage versus like Part G or a supplemental plan. So when you turn 65 or have certain chronic disabilities, you get Medicare. Medicare is a governmental, federally based healthcare system where they will pay for a certain amount of your healthcare. Now, they will pay up for up to 80%, but that extra 20% needs to be covered somewhere or out of your pocket, which I guess you could do. And that's where these other plans come in, and they have different, not numbers, letters for what they are. So basic Medicare is Part A. All right, and then Part
A is what, in the hospital?
Yeah, hospitalization.
Yeah.
That's and then outpatient is B, and then
so we work with
right, and then a Medicare type Advantage plan is C. Maybe. Anyways, Part D is prescriptions. I know that, and then the supplemental plan maybe G. I guess that's. But anyways, the big ones we're talking about that we deal with are Medicare Advantage plans versus Medicare with a supplemental.
Yeah.
So Medicare Advantage plans is essentially a where Medicare, a government agency, allows another insurance agency to provide.
It's the privatization of public.
Yeah. So they give them a certain amount of money, and then they have to use that money to care for their patients.
So interesting.
Obviously, some of that comes from patients too.
Some of ours is United Healthcare, but you were right. They're either shutting down all or
one of those at least.
Some of their plans.
Locally.
But there's the other ones that we still have are non-United Healthcare players in the Medicare Advantage.
I don't know how many there are, but yeah.
But they all function the same, even though they're different insurers for Medicare Advantage. When they come through our system, they're all treated roughly the same.
Yes.
I mean, there may be minor.
Yeah.
We're not aware of the
differences between
them because they don't affect our care of the patient.
Right.
We treat them all
so that's Medicare Advantage. Typically with those, you have a copay for a regular doctor's visit, but your annual wellness visit for anybody, there's no copay. And then the other one is Medicare with a supplemental, where that supplemental insurance allows Medicare to do its job and pay for pay the doctor or the hospital, or well, I guess the doctor at this point, for 80%, and then they pick up that 20%.
Yeah.
Let's see, differences. Medicare Advantage are typically an HMO, so they're based within a system. Locally, it's called Sutter. That's our big system. There are other ones that are, UC Davis. These are local ones.
So
UC
I just
Davis,
dealt with that today.
Mercy, et cetera.
The difference there, a patient who lives in Grass Valley.
Kaiser's a common one too.
Yeah, they're closed system.
Yeah.
Lives in Grass Valley, wanted to go to a physical therapist up there, but had the Medicare Advantage.
Had to go to a Sutter.
Well, Medicare Advantage is with a system.
Yep.
So they didn't have the option
that.
of doing it up there.
Yeah.
And so you got that regional aspect too.
Right. Yeah. So Medicare with a supplemental is a PPO typically. So you can go anywhere. They say that you don't need a referral, but I can tell you that all specialists want a referral.
That's up to the specialist.
It's not up to the patient. So that's up to the specialist. So often we need to make that referral as primary, which is appropriate. We don't want our neurosurgeons seeing everybody who threw out their back. So we want to say
the neurosurgeon may not want that.
But that's what I'm saying. Yeah, they probably don't want that.
Then again, somebody who's bad and nobody's referring to them, and maybe they're just fresh out of residency and they have no business. Maybe they do want to see.
I guess maybe
everybody with back pain.
Yeah,
it could be. I don't know.
Yeah. I think those are the major differences. And with the Medicare with a supplementary, there typically is no copayment, although those are typically a little more expensive.
Yeah.
So that,
Yeah. And from the physician's perspective, at least the way they do it in our system, we actually prefer to have the Medicare Advantage.
Which is actually capitated, which I'm throwing out another word here.
Yeah, they don't know that.
Yeah. Meaning we get paid per patient per month, not by the visits the patient come in to
So that
see
can
us.
go either way. That can go really bad for the patient.
So I can see that be done poorly, but it can also be done well.
Or really good for the patient. So if you had somebody who was gaming the system and didn't have a heart for taking care of their patients, they would just not take care of their patients.
Never see their patients and get paid.
Still get paid. And then the way we look at it is, okay, we're getting paid whether the patient comes into the office or not. What do they need? Let's just take care of it. Is it something we need to see them for?
Yep.
They need to come in for that. So that's constantly what we're doing with the messages that come in on the phone throughout the day is this something that we should see in person, or is this something we can just take care of?
Yep.
And so we make that judgment based on
you don't need to.
your description. Or sometimes we'll say, we don't have to have them come in because we don't get
Paid extra.
We give a copay, but that doesn't cover the cost of the MA in the room that they use. So really, that's a wash.
Right.
So we really look at it as what information do we need? For example, I had a rash, and the patient took great pictures of the rash, sent them in through the computer. I did not have to see that person,
able to take care of it
in person. I could see obviously what we were dealing with and send in a prescription for what was going on, without making them come through our doors. It was pretty good.
Yeah.
But yeah, we have such a preference for the Medicare Advantage currently with the way we're set up versus straight Medicare that we're not currently open to the Medicare
Straight
or Medicare with a supplement.
Yeah.
Because we're just limited to how many patients we only have so many providers. We have many more patients trying to get in than we can.
Right.
So we tell them, you can get into our office. All you have to do is just go with the Medicare Advantage plan, and you'll be assigned our name on your card.
Well, you need to request that, but you can.
It works out better for us, and it allows us to have some kind of way of having a limitation of how much volume is coming in the front door, to make it doable. Oh, we have a comment from Rusty B.
Another comment.
So, supplemental does not have insurance company supplement
approvals. If Medicare covers it, you're right. So these secondary insurances that kind of back up what Medicare does, if Medicare covers it, they cover it. If Medicare does not cover it, they do not cover it. So they write along party lines, whatever lines you would call that, of what they do and do not cover. So that's very true. They will, if Medicare covers it. Now, typically, if Medicare covers something, Medicare Advantage will cover that too. And actually, it goes beyond that in that for certain, a good example would be vaccines. Our Medicare Advantage plan will cover vaccines.
The tetanus shots, for example.
Like a tetanus shot for just booster purposes, not if you have a cut or wound. Those are covered by our Medicare Advantage insurances and not by Medicare and a supplementary. In our office.
Yeah, RPM, the home blood pressure monitor that we monitor the readings remotely through text messaging technology, that is covered without a copay with the Medicare Advantage plan. People who don't have that, they have to have a supplement that's going to cover it, or they're going to have to pay actually 2 copays for that program. So that's one of the reasons I really like it.
Because we enjoy that. And
I think the physical therapy is covered too through the Medicare Advantage, and I don't know if it is. If you,
it's a good question. It probably depends on how how the insurance is set up. Read the fine print when you sign up for insurance. Make sure you know everything about it.
Well, and
on both sides,
something that's important to our patients is medications. Which,
absolutely, that's Part D,
and it's different with all the different companies. So you have to go through.
Yeah,
you actually have to have your list and go through. And I think some brokers will do this with patients.
What do you take in? Let's line it up. Yeah. So every insurance Part D, which is medication insurance coverage, has certain preferences, and typically it's generic medications over name brand medications or newer medications.
Yeah.
We're pretty good about prescribing generics anyway. So typically,
and it's
that's
actually
not
the
an issue for us.
exception where you
Have to switch.
like if I was the patient, and let me get off of that comment there. If I was the patient and was being prescribed a medicine, very, very few circumstances where I want some kind of new medicine that's not generic yet instead of a generic.
Right.
The vast majority of things, there's so many medicines now at this point that have gone generic that are just fine.
That works great.
Diabetes is an area where we do run into.
We need more there.
I'd like to use the GLP-1s more. I'd like to use the SGLT2 more.
Blood thinners is another one I can think of.
Oh, yeah. The anticoagulants. That's a field where we're really waiting for some agents to go generic.
Some of those medications, diabetic medications and the anticoagulants, are actually on the list of some of those.
Oh, that's right. I forgot about that. The current presidential administration got these 10 drugs.
Yeah.
Just slashed the prices so they're like $150 a month instead of $600,
$600,
sometimes $1,000, depending on the drug.
Yeah.
Yeah. So that's something coming up next year for people who are taking anticoagulants.
Some of those.
Now,
we have to look at that
for some people, that's still expensive. $150 a month is still expensive for some people.
It's
for a lot of people, that's
for a medication. That's a lot every month for a year.
If you're not already spending it,
Yeah.
And it's not that there isn't a generic alternative. The problem is the generic alternative is you have to get your blood drawn at least monthly to get a test. And the dose has to be adjusted according to the results of these tests if it goes out of the parameters. That's why the newer anticoagulants are so great, because you don't have to do the testing. It just does its job.
Right. Yeah.
It may even be safer because you don't have to do the testing. Certainly. Yeah. If I was the patient, I would want a novel anticoagulant.
I would.
And not be on warfarin. Mm-hmm. But to pay what they cost with... That's a lot of money.
You need some of those covered, for sure.
So, $150 a month would be much more doable.
Right.
Many more people are going to be able to cover that than $600.
Yeah. Yeah, especially when some of these newer treatment models call for some of these more expensive drugs that put you in a pickle.
Especially people with heart failure.
Yeah, heart failure is exactly what I was thinking of.
The SGLT2.
It calls for newer medications that are not covered typically. But anyways, that's a whole nother tangent we could go down.
We're already on the path to these medicines being generic. It's just
going to take time.
Putting in the years.
Will your heart failure hold out another 5 to 10 years?
On the drugs, yeah.
On the drugs, they just...
On those drugs, it will. That's what's so great about them. The heart failure drug, I'll just throw this in. We're getting towards the end here, but I'll just throw this in. The heart failure drugs, the success of them is something that no patient is going to easily sense.
Right.
Because
it's very subtle.
If you're not on the medicines, you're likely going to have an exacerbation and end up in the hospital very sick. Sometimes people die when this happens. Some people with heart failure admissions die. And the people who are on the medicines at the recommended doses much less often have exacerbations and go to the hospital. So it's a real hard thing for the patient to sense while they're spending the money and taking the medicine what they're
because it's
not
a negative.
You don't sense a negative.
Right, yeah.
I say it so often. Thank you, Dr. Gwain. You're very knowledgeable on these things. Thank you.
Yeah, I have to talk about this with my patients all the time. You do too, I'm sure.
And thank you to Lindsay Antoine. Let me put that up there again. Lindsay Antoine.
Yeah,
thank you, Lindsay Antoine.
Appreciate it.
That's really cool. We appreciate you using the super chat there, and it's appreciated. We did enjoy our Dutch brothers today, so thank you.
Yeah.
Anything else?
I don't think so.
Okay, so getting towards the end of the year, we hope that holiday season is great for all of you. We already had Thanksgiving here in America. And hope that was great.
If you're looking for something to donate to as you come to the end of the year, I hear a certain
Hillman
Foundation has an anonymous donor who's matching.
That's right.
A certain.
You can look at the Facebook page of HillmanFoundation.org on Facebook and give to the Hillman Foundation. That'd be really cool.
Yeah, it does twice as much. You get a little tax deduction. Hey,
there you go. Thank you for thinking of the Hillman Foundation. That's the way to go. HillmanFoundation.org.
I'm a Hillman, former Hillman.
That's right.
You are. My son is a current Hillman.
Yep.
In the best of times.
In the worst of times.
It's great to be
here.
Yes.
Until next time.
Hey, I'm Dr. Wayne Vaughn.
Dr. Mark Vaughn telling you to stay in good health. Thank you.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.